So, good morning, everybody. I can't see anyone, but you're all very welcome. I hope everyone's doing very well. Thanks for coming to the talk. So, my name is Imogen. I'm a speech and language therapist and a clinical audiologist. And today I'm very excited to chat to you about this presentation, which deals with otitis media with effusion and its potential impacts on speech and language development. So, over the next 30 minutes or so, we will discuss the auditory pathway. So, what is the auditory pathway? Why is it important? Just a brief overview of the different types of otitis media with a specific focus on otitis media with effusion. We'll delve into the impact otitis media with effusion can have on speech and language development. We'll look at the speech banana and a few different hearing thresholds and what this means for speech and language development. And then I'm happy to open the floor to any questions. And my hope is that by the end of our time together today, you'll leave with a better understanding of otitis media and how this can impact speech and language development. So, we'll get right into it. So this is a picture of the auditory pathway, and the auditory pathway refers to a series of events that can occur in the ear and the brain which allow us to perceive and interpret sound. So the process can be broken down into several different stages, and we'll go through each now. So firstly, we have sound waves. So sound starts with sound waves in the air, and these sound waves are generated by different objects like your vocal folds when you speak or a musical instrument that people play. So then these sound waves are collected, processed and transferred by the different parts of the ear, and the ear can be broken down into three parts: the outer part, the middle part and the inner part in here. So the outer part is the collection point, so it collects and directs the sound waves into the middle ear. So the outer ear is out here, it is the part we can see, and it consists of the pinna and the external auditory canal. And the canal's job is to transmit these sound waves to this part, the eardrum. So the eardrum starts at the middle ear starts at the eardrum. The eardrum is a thin membrane that vibrates in response to these sound waves, and behind the eardrum there are three small bones called the ossicles. They are these bones here, so we've the malleus, the incus and the stapes, and they act as an amplifier. So everything that goes into the middle ear, they make it louder, and they then pass it on into the inner ear. So the inner ear is known as the organ of hearing, the cochlea. This is the cochlea. It's a spiral structure that contains fluid and hair cells. The vibrations that are coming from the middle ear cause this fluid to move, which causes the hair cells to bend, and this is what generates electrical energy. And these electrical signals are then carried to the auditory nerve. We won't speak too much about this part, but basically the auditory nerve carries electrical signals to the brain, and the nerve fibers carry information all around to the different auditory cortexes and so on, and it's within the auditory cortex that we can interpret these electrical signals as sound. The different aspects of the cortex handles different parts of our sound. So one part of the brain is going to tell you what pitch someone sounds, others will tell you the tone they're using and where the sound is coming from itself. And then within the brain, all of this information is combined, and then we just perceive it as sound. So I suppose that's important going forward, particularly the middle ear information, as otitis media predominantly impacts the middle ear. Okay, so Next, I just want to speak briefly about what is otitis media, because there's a few different types. So as a whole, otitis media refers to a group of conditions that involve inflammation or infection within the middle ear. And if we can remember back, the middle ear is that space between the outer and the inner ear with those three little bones. And the three main types of otitis media that can occur is otitis media with effusion, which we'll be speaking about in detail today, acute otitis media, which we'll mention briefly, and then chronic otitis media, which we unfortunately won't be going into today, but it's just a chronic or persistent type, and can be a mixture of the two or isolated to one. So, with that said, what is otitis media with effusion? So this is what's commonly known as glue ear, and there's a few different characteristics of it. So firstly, it includes fluid accumulation. So otitis media with effusion is defined by the gathering of fluid within the middle ear, and it can be various levels of thickness and consistency, and it can occur for a number of weeks or a number of months. I suppose the main defining feature between otitis media with effusion and other types is that it is usually absent of acute infection. So while otitis media with effusion does not generally have any ear pain, redness, pus or discharge, it's considered asymptomatic, but it can have mild sensations such as a sense of fullness in the ear or pressure in one's ear. It can cause a hearing loss, so the presence of fluid in the middle ear can lead to usually a temporary, mild to moderate, what's considered conductive hearing loss. And while it is usually temporary, if it's left untreated, it can impact on speech and language development, particularly in young children. And I suppose we don't really know what the exact cause of otitis media with effusion is. It's linked to lots of different factors, including allergies, respiratory infections, and dysfunction within the eustachian tube. The eustachian tube is really important in otitis media with effusion. It's a little tube that connects the back of the throat and the nose and the ear. And basically, if the tube is closed or if it's blocked or anything like that, it prevents pressure from equalizing and it prevents any fluid that might build up from draining. So next we have a diagram of what's considered to be a normal middle ear and also what's considered to be a middle ear with otitis media. So on this side we can see the middle ear. We can see the eardrum first of all, and that appears to be translucent and it's doing its job separating the outer ear from the middle ear. The middle ear space here is typically filled with air and the three bones as discussed. And what's important is that we can see down here, this is the eustachian tube, this is open, it's allowing the pressure in here to be equalized, and as you want it to, it's not allowing any fluid to build up, it's all being drained straight away. If we look over here to the middle ear, which is considered to have otitis media, we can see that there is a fluid build-up here. So it's a little bit difficult to see, but you can see it's kind of a dark brown, and these yellow little spots indicate fluid. So I suppose first of all, what you might notice when you look into an ear is the eardrum might be a little bit cloudy, or it can be dull because of the fluid behind it. Also, because there's fluid behind this eardrum, it can be very difficult for the eardrum to move, so it's a little bit less mobile, and this impacts how the sound is transported. And I think what's very, I suppose, important to note that is this eustachian tube, it's closed, so the pressure isn't equal in this ear, and there is no way that the fluid can be drained itself. So we would have to wait until that eustachian tube is opened, or if intervention is supplied to open it. Now, what I'm going to show next is just a few real life eardrums. So for anyone who's a little bit squeamish, it might be good to look away now, but it's nothing bad anyway. So here are three different eardrums. So if you look into an ear, this is what you could see. So I'm going to start with this one. Again, it's considered to be a typical or normal eardrum. There's a few different hallmark features you look for when you look sticky thing here, which is actually one of the bones in the middle ear, and this little light. So that shows us that the light is passing through the eardrum. There's no fluid or anything there, so that would be considered a healthy eardrum, or it would have no abnormalities. As you can see on this eardrum, we can see all these little air bubbles. Now, it would be quite unusual to see an eardrum with air bubbles this pronounced, but that would be a certain, or very likely indicative of fluid behind that eardrum. You can also see that around the eardrum it's quite red. That would be described as an angry ear or an angry drum, and that's often linked with kind of infection building up. And then over here on this side, while it is harder to see, it's slightly duller just within the body of the eardrum itself, and that again could possibly indicate that there's some fluid behind that eardrum. So I think what's important to know is the difference between symptoms of acute otitis media and symptoms of otitis media with effusion. So these are the two most common types of otitis media that can occur in children. It's estimated that about 50 to 70% of children will have one of these, if not both, at some point, kind of under the age of 3 to 5. And what do they look like? So in the acute otitis media, they occur rapidly. It's an infection the children will have earaches, they will spike temperatures, they'll generally be sick, and sometimes you can notice pus draining from the ear. So that means the eardrum itself has actually burst to let out all that fluid and infection, and it often kind of heals itself. It doesn't always heal itself, but it often will. Then in otitis media with effusion, it's a little bit more tricky because you don't have those associated infection signs with it. So while you may have hearing loss, you'll likely just have a feeling of fullness or pressure in the ear. Sometimes children might pull their ears. They might have difficulty hearing very soft or high frequency sounds, which we'll be discussing a little bit more. And often in the clinic, we see that otitis media with effusion can be linked with kind of persistent nasal issues, tonsillitis, kind of those congested children who have speech sound difficulties. They are often linked with this otitis media with effusion because it's more long term. So this fluid can be there unnoticed for a while, whereas with otitis media it's generally not as likely because the child will just be really, really sick for a few days, then it'll resolve like an infection. Okay. So there's a couple of different, I suppose, risk factors or red flags for otitis media with effusion that can put a child at more of a risk of having it than other children. And I've separated these into kind of medical and non-medical factors. I suppose the big one is age. So otitis media with effusion is really prevalent in the pediatric population, particularly children aged between 6 months and kind of up to 3 years. And there's a few different reasons for this. So first of all, it's because of their anatomy. They're still growing, so everything is really, really small. And that includes their eustachian tubes. So in children, eustachian tubes are actually quite horizontal, and they're narrow. And they're shorter. So when anything goes into the back of the throat, the nose, because it's so horizontal, everything can just pass up into that ear, and then that facilitates fluid accumulation, and also the adenoids in children are often larger, so they can kind of impact as well the eustachian tube and how fluid and things can pass through it. I suppose family history plays a role in lots of things, and genetic factors can certainly influence the structure of the eustachian tube. So yeah, like if you have, you'll often hear of families having grommets, first cousins have grommets, uncles have grommets, that kind of a thing. So I suppose that would put you you'd be ticking a good few boxes for red flags there for otitis media with effusion. So children or adults who are exposed to tobacco smoke or other environmental pollutants in the house or just in their environment, it does reduce their their ability of or chance of acquiring otitis media with effusion, and that's because this smoke actually irritates the eustachian tube. And then because of back to their age again, children who are in childcare, especially at a young age, do have an increased risk. I suppose that's not something that can be helped, and particularly after COVID, I think when a lot of children's immunities were just down anyway, we definitely saw spikes in these things, but it's just something to be aware of more that needs to be changed. It doesn't. Then there is some medical red flags for otitis media with effusion. So one would be that history of acute otitis media, so ear infections. So if a child is having repeated ear infections, lots of antibiotics for ear infections within a 12-month period, you would be looking at maybe risk factors for otitis media with effusion. Recurrent tonsillitis and nasal congestion, as I said, so they often involve bacteria and viruses within these infections. And then, as I said, these infections can just spread to the eustachian tubes into the middle ear, and that leads to inflammation and fluid production. There's some research now to suggest allergies like hay fever and respiratory allergies can be associated with otitis media with effusion. Again, it's thought that they're linked to kind of inflaming and irritating the eustachian tube, and that impacts its ability to function in what's considered typical. But I think more kind of research is needed in that area. And then certain craniofacial abnormalities, so certain structural abnormalities in the head and neck area can be associated with increased risk of developing otitis media with effusion. For example, in the cleft palate and Down syndrome population, often the outer, middle ears and eustachian tube functioning are impacted. I suppose it's important to note that while these factors can increase the risk of having otitis media with effusion, they don't guarantee that you're going to develop the condition. So not every child who has a family history of grommets or, who has had recurrent ear infections is going to develop these things. And it's important to note that these are also risk factors for adults. It's less likely that it will occur, but it can occur. Okay, next we're going to talk about the treatment. So the treatment approach for otitis media with effusion depends on lots of different things. So you consider the severity of symptoms, the duration of the fluid, how long has it been in there, does the child or patient have any other underlying conditions that you need to consider, and I suppose often otitis media with effusion will resolve on its own. So that's the big thing. Like often children will have this and you won't even know about it, and they can clear the fluid themselves. So their eustachian tubes will close for a while, maybe while they have the cold, but then it will open, and it takes a little bit of time, but it does happen itself, and that's considered spontaneous. But then some children, they won't be able to clear it, and that's where intervention comes into play. So within the protocols of the HSE, the first step, I suppose, in the intervention process is considered to be this watchful waiting. And this means that basically when a child presents to clinic with suspected otitis media with effusion, they will actually be waitlisted for a further 3 to 6 months, depending on whether the otitis media is in one or both ears. And this is just to see if the child can actually clear it themselves. If after that 3-month watchful waiting period has ended and there is still fluid, at this point it is considered to be persistent, and this is when you may consider onward referral to an ear, nose and throat specialist to consider putting grommets in. It is ultimately the decision of the ear, nose and throat doctor that will decide whether a child is suitable or not for grommets, and basically a grommet involves placing a small tube through the eardrum, which can allow drainage of fluid, and basically this allows for equalization of the pressure because it allows that eustachian tube to open. The only function of the eustachian tube is to open, because this keeps everything else balanced. So that's what the grommet does effectively. Sometimes hearing aids will be considered for children who have otitis media with effusion. So, it's because of lengthy wait lists at the minute. So if children are waiting quite a while to be seen by an ear, nose and throat doctor, and maybe after a decision is made to get grommets, there's still quite a time between those two appointments. That's valuable time that children can be having access to speech and language, so they may fit hearing aids. And I suppose it's important to note that with otitis media with effusion, while it causes a hearing loss, it doesn't impact one's permanent hearing. So often we say that the underlying hearing is okay, and it's just that the sound can't get to the underlying hearing to be processed, and all that has to happen is you have to make the sound louder, and then it will actually get to the cochlea and be processed by the brain. So it's just a blockage getting there, and that's why hearing aids are introduced. Also, hearing aids are sometimes recommended for certain populations. So, for example, in the Down syndrome population, because of anatomy and things, their ear canals can be quite small and narrow and difficult to fit grommets. And in that situation, then hearing aids may be the first protocol for treatment. Sometimes antibiotics are recommended if it's suspected that there is an acute otitis media, and that's only to treat an infection. If it's pure otitis media with effusion, there is no infection, so antibiotics are generally not the first protocol, but that's down to the decision of the GP and the ear, nose and throat doctor again. And clinically, I have seen a lot of nasal corticosteroids or decongestants being prescribed, if they feel that kind of this otitis media is stemming from allergies. But again, that's kind of down to the ear, nose and throat doctor and GP and the parent to have a discussion around that. And I suppose it's really important that if you have a concern, you kind of consult with your healthcare professionals. And in terms of otitis media with effusion, it would be your audiologist, your GP, your ear, nose and throat doctor, and your speech and language therapist to a certain extent, when you're making, the best possible treatment plan. Okay. So what I'm going to show you now is just some different types of treatment. So over here we actually have a grommet in an eardrum. So that grommet is considered to be in situ. So as you can see, it's a tiny little tube that just sits in the eardrum, and it allows that pressure to equalize. It allows that eustachian tube to stay open, and then over time the grommet will just fall out. So often parents will see that the grommet's maybe on the pillow in the morning when a child wakes up, and then the eardrum is great because it just closes itself, so it just heals like any other wound or cut. And often children might need a set of grommets or maybe 2 sets of grommets, so it wouldn't be unusual, to have maybe not multiple sets, but maybe 1 or 2. Here we have a little girl wearing what's considered to be a soft band kind of hearing aid. It's a bone anchored hearing aid, and basically it sits behind the ear as it's seen here, and it bypasses all that fluid. So it sends the sound directly into the cochlea, and where it can be processed, and it doesn't account for any fluid. And then on this side we have kind of traditional hearing aids, for want of a better term. So you have your little earpiece that sits into your ear, and then you have the kind of technology aspect which sits over the ear, and they can be programmed to the hearing loss that the child has, to make sure that it's loud enough for the sound to bypass the fluid and get into the ear. So they're kind of the 3 main intervention options. Probably grommets are quite common, but as I said, in some situations hearing aids will be offered. Maybe both will be offered as well sometimes. Okay, so what we'll do now is we'll get into kind of the speech and language therapy aspect of it, and kind of discuss the impacts that otitis media can have on speech and language development. So one of the main reasons that you provide intervention to children who have otitis media with effusion is to prevent developmental consequences. So for example, the distribution and variability in auditory input caused by this fluid can cause children to hear and process information completely inaccurately. And this then goes on to impact their phonological working memory, and it really generates a build-up of incorrect words. So they're hearing words wrong, but they think they're hearing it right. So that causes, a knock-on effect for all aspects of language. The literature conducted over the last kind of 30 years is a little bit inconsistent, considering speech and language development and otitis media, but I suppose there is a certain consensus that studies have found links between children who have an otitis media when they're young, and then this having a knock-on effect with both their understanding and use of language when they kind of hit that preschool, primary school level. And I think we're also seeing that now, particularly post-COVID clinically. Obviously that's very anecdotal, but it there is some kind of indications that this is a problem. I suppose otitis media impacts speech and language development in a few different ways. So first of all, it causes a temporary hearing loss. So it usually results in mild to moderate hearing loss, and then this impacts how sound is transmitted through that auditory pathway, particularly in the middle ear. And then when the child experiences a hearing loss, they can have difficulty hearing sounds, processing sounds, and then that impacts language development. It can also actually impact their auditory processing. So when there's fluid in the middle ear, that dampens the sound vibrations, and it makes it more difficult for children to perceive and distinguish between different sounds. And then this can impact their ability to develop phonemic awareness. And phonemic awareness is the ability to recognize, identify, manipulate sounds in spoken words, and that's crucial when you're learning to read, write and spell. I suppose it has been linked to language delays. So in speech and language, I always tell parents to consider speech is like your pronunciation, your speech sounds, and then language is everything else. So how you use language, your sentence structure, the amount of words you have, your understanding, that kind of a thing. And there is some links to suggest that children who have persistent or recurrent otitis media with effusion do have language delays, and it can be seen for problems with vocabulary acquisition, sentence structure, and just overall use of language. And then additionally to that, we have the articulation and pronunciation aspect. So, it can impact the ability to perceive and imitate certain speech sounds, particularly high frequency speech sounds, which we'll be discussing. And then that can just lead to children kind of saying incorrect words. So, for example, you have speech sound errors. So, fish might be fit, or chair might be tear. Or people might describe the child as having kind of a muffled or dampened voice quality, and that's because that's how they're hearing it. So sometimes people will describe it as sounding like they're underwater, or the child might describe what they're hearing as being underwater, and that's basically because that's how they're hearing it. Everything that's been said is being dampened down by that fluid. And I suppose considering all of that, it can go on to impact social and academic success. So speech and language are fundamental for communication interactions, social interactions, and academic success. And children who have otitis media with effusion, I suppose the language delays that are coupled with it can face challenges in lots of areas in the classroom, from participation to developing relationship with peers to just effective interactions in general. So again, it's important to note that while this can happen when children have OME, it's not necessarily going to happen to every child that has an otitis media with effusion. Some will experience delays, some won't. But it's important that if there's a suspicion that this may be occurring, to get diagnosis and treatment promptly, so the best possible intervention can be implemented. So what I just want to have a look at here is just the hierarchy for how you acquire speech sounds. So this is how we basically learn how to talk, and what I want to draw your attention to is this very bottom tier. So as we can see at the bottom, listening and attention kind of form the foundation for how children learn everything else. So if you can't hear, you're not going to be able to listen, and that's going to impact your attention. So basically, if hearing is impacted, which is right down here at the bottom of the hierarchy, everything else is also going to be negatively impacted. So it really plays a role in all aspects of acquisition when you're small and you're learning all your speech and language. So on this slide, we're just going to focus purely on language development. So hearing sounds and words does help children learn to understand and talk. So children learn so much accidentally, and I suppose if a child has otitis media with effusion, they're going to miss out on some of this language, and then this can result, as I've said, in problems with speaking, reading, school success, and social skills. So a few interesting points are that children with otitis media with effusion may not learn words as fast as those who have typical hearing, and furthermore, it's easier for children to learn concrete words like cat, jump, 5, so things that they can see, but it's not so easy to learn abstract words, so before, equal to, like, and, are. So those more abstract, there's not a picture for them, there's not an action for them. Children with otitis media and effusion also can have trouble knowing the different meaning between words. So, for example, the word bat, as we know, it can be describing an animal or a type of sport equipment, and children with otitis media have been proven to just not be very confident in knowing these several meanings for the same word. And I suppose important to note is that children with otitis media can fall behind children who are the same age, who have typical hearing, and don't catch up without intervention. And we're talking kind of preschool, starting school age to early school years, that kind of age group. So next we're going to talk about speech. So children with hearing loss cannot hear the sounds as well as children. And then this impacts on their speaking, so the clarity of their speech and the errors that they have in speech. All frequencies can be impacted, but the main frequencies that are sometimes impacted are considered high frequency sounds, and that's s, sh, f, t, k. So those kind of consonant sounds, and they're really important to ensure you know the clarity in your speech. And they're really difficult for children to hear in the presence of fluid. And also what's interesting or important is that when children have flu, they don't hear themselves talking back, so they're not receiving any auditory feedback to regulate themselves. So this can mean that they're speaking too loud or too soft because they can't hear their own volume, and they also might be speaking in a really high pitch or low pitch, and they might be mumbling or sound different to what other children sound like, but they don't know that, and it's really difficult for them to correct these mistakes when they can't hear themselves. So what I have here is an audiogram and a speech banana. So I'm going to talk you, when a child comes in for a hearing test, this is kind of what will be shown in the results. So on the screen, this whole graph is an audiogram. An audiogram basically helps us, it helps us to plot hearing abilities of a child. And it's really important when you're considering speech and language development, because all of the speech sounds that we acquire are plotted somewhere on the audiogram. So if we look at the horizontal axis here, we can see that this is the frequency or the pitch of a sound. So down at this side, we've kind of those lower pitch sounds, so a tap, dripping, or even like men's voices, so they wouldn't be very high pitched sounds. Whereas at this end of the graph up here, it's kind of more your high frequency sounds. So children's voices, women's voices, shrill singers, like that can really hit the high notes, that's up here. On the vertical aspect then, we have basically how loud a sound has to be to hear it. So kind of up on this end of the graph, it's very low sounds, so taps dripping, leaves rustling in the wind, footsteps. And then down here, we have the really, really loud sounds, so lawnmowers, concerts, jet engines, that kind of thing. So in the middle of the audiogram then we have the speech banana, and this refers to a specific region, okay, that covers all the speech sounds that we need to be able to hear and use to ensure that we can speak properly. And basically the speech banana, as you can see, it ranges kind of from 25 to kind of down just before 60 decibels. So that's how loud you have to be, and it goes all the way across. So there's some low frequency sounds and there's some high frequency sounds. And if they're impacted, depending on the level of hearing loss, that can result then in speech and language difficulties. And I'm going to go through a few different types of hearing loss just to show you how a child, I suppose, can miss out on certain aspects of language. So what we have here again is an audiogram, it's just in a different way, and the speech banana. And this graph represents kind of a mild hearing loss. So when we say a mild hearing loss, it's anywhere in between these two red lines. So if a child has a mild hearing loss of, let's say, 30 or 25-ish, that's about this red line, they can't hear anything above the red line. They can hear everything from here down, but they can't hear anything above it. So if a child came into the clinic and had a hearing loss just at the red line, that probably wouldn't have a massive impact on their speech, because you can see all the speech sounds are lying below their level of hearing. So they have access to all those speech sounds. It is possible that they might have difficulty hearing some faint sounds, but it's likely they'll be fine. However, if you look at, let's say, the 40 dB mark, okay, so if a child's hearing loss was at this red line here, everything above the red line they can't hear, okay? So low frequency sounds they're going to be fairly okay at. They're going to miss this one here and this one potentially. But as you can see, there's lots of high frequency sounds in the area they don't have access to anymore, so they're going to miss all those sounds. So when they hear fish, it's not going to be f anymore for them, it might be b. Okay, so it's all going to be dampened down. So these children who have a hearing loss kind of at this red line, so the lower red line, will probably have difficulty in school. They'd benefit from being positioned near their teachers. They're going to struggle in a noisy classroom environment, and they're probably going to be depending a lot on speech reading and kind of environmental cues to pick up on what's happening, and they're really good at masking. So children in this bracket are very good at not letting on that they have a hearing loss, and then it can actually go unmissed or missed for a while. and likely they are going to have pronunciation issues. So when you have the kind of 40 dB loss here, you're going to have issues with F's, TH's, S's, K's, P's, and a few of the lower frequency sounds. And on this slide, we have what's considered a moderate hearing loss. So these are hearing losses that can occur with fluid in the middle ear. Okay, as I said, it's usually mild to moderate, so we're within the realm. And as you can see, most to nearly all of the speech sounds now are being cut off. So if a child has a hearing loss at just the start of the moderate bracket, so at 40, they can't hear anything up here. So again, we've all of our high frequency sounds, and again, we're touching into the low frequencies. If we go to the other extreme of moderate, okay, down here at 70, now the child can't hear anything above this red line. That's all of the speech sounds we need to have access to in order to develop speech and language. So if you have a child who is learning how to speak and they're trying to have access to speech and language, if they have a hearing loss of 70 dB, they don't actually have access to any of that, and it's all going to sound muffled and distorted to them. So children will need favourable seating in school. They can miss up to 50% of what's happening in the class. They're going to have speech difficulties with lots of different sounds, and they're probably going to have a very limited vocabulary in compared to their other age-appropriate kind of typical hearing peers. Now, it's unlikely that fluid is going to cause a very severe hearing loss of 70 dB, but it's very likely that you can get a child, with a hearing loss kind of at the 50 or 60 level. So that wouldn't be unusual. And at this point, you would really be considering grommets, if they're appropriate, hearing aids to try and ensure that child is getting access to all the speech sounds while they're waiting to see if grommets are appropriate. So that's what I'd be pushing for in my clinic. Okay, so just to conclude the presentation, I suppose there's a few things you can do if you're concerned that your child might have an otitis media with effusion, and if they have co-occurring speech and language difficulties, or if they have speech and language difficulties and now you're thinking maybe it's caused by otitis media with effusion. First of all, I would really recommend you consult with the correct professionals. As I said, for this area of concern, it's your GP, they'll send out your referrals, audiologists, speech and language therapists, and then through those professionals they will send you on to ear, nose and throat professionals or anyone else they feel appropriate if needed. It's really important to follow the treatment recommendations, so if hearing aids are recommended, why are they recommended, and use them. If you don't, if it's in the drawer, it's not going to help, and often people will get hearing aids and they'll take them home and they won't wear them, and there is certain stigmas around hearing aids, and I understand all of that, but really they're a temporary measure usually when it's otitis media with effusion, and they can have a massive impact. Speech therapy, there's loads of evidence to suggest that early intervention is key. Loads of children are coming, presenting with suspected otitis media with effusion, and starting speech therapy before they start school, because it can have such an impact when they are trying to, that phonological awareness, reading, writing, spelling. So it's better to have that done where possible before they have to start doing or learning to do those skills. I would suggest to all parents who think maybe there's an otitis media with effusion to monitor their child's hearing themselves. Now, it's a difficult thing to do, but sometimes you can notice a regression in a child's hearing. So they might start sitting closer to the television. They might start asking you to repeat yourself more. This all might be linked into times when they're really stuffy and have nasal congestion and all the rest of it. And that can maybe be some, informal evidence that, okay, maybe there's a bit of fluid moving into this ear. They also might start to have regression in their speech. So they might actually do really well with their speech, then be hit by kind of that runny nose, tonsillitis-y kind of infections, and then you might notice their speech takes a dip. That's not unusual, and that's kind of characteristic of an otitis media with effusion. And I suppose the main thing is to be patient and supportive with both the children and the healthcare professionals. There is waiting lists at the minute, and people are working as fast as they can to kind of clear those waiting lists, but unfortunately they're there. And I think the best thing to do is if you're suspecting it, and get them checked out sooner rather than later. So if they do need the intervention down the line, they've been seen, they're linked in with the system. So what I'm going to share, so thank you for listening, first of all. I've left my contact details for Kat there, and I am happy to answer any questions now. But just before we do that, I want to draw your attention to some important links. So I've left a speech and language referral access kind of contact details there to those email. I've also put a link into the HSC audiology contact details. So depending on where you are in the country, this is a list of all the areas that there's a HSC audiology department and their numbers, so you can ring to get a referral form, or you can ask your GP to refer you in if you suspect any difficulties. There's also an NHS information sheet on glue ear, so just if you want to do a little bit more reading, and there is some more reading from the HSC on otitis media, acute otitis media, so yeah, I just thought I'd draw your attention to them. Now, so I'm going to stop sharing. Okay. Now, so if anybody has any questions, I'm happy to take them. And if anybody wants to send questions privately, that's absolutely no problem as well.
Hi, may I just?
Hi.
How are you? Just a quick question. We have a child within the preschool, and what we notice is there's 20 kids. So if we have only a small group in, he's fine in hearing. But with the big group,
Okay.
all the noise, he can't hear. So what we've kind of started doing is laugh with him, because then he doesn't get frustrated. But I don't know if we're doing
Okay.
right or wrong. We've asked mum to get his ears tested. And
Okay.
he also has very bad balance, like he'd stand up, fall over his feet, or he'd get up off the chair, next thing he's on the ground. Now mum hasn't got his ears tested yet.
Okay.
And then his speech, his pronunciation is not great. Now he is only 3, but
Okay.
I'm just wondering, is there any other strategy maybe we should try? Or
I suppose he has a few risk factors for otitis media with effusion, but he has a few risk factors for other
yeah,
things as well. The balance system is within the ear. Now, we didn't go into detail in that at all today because it's beyond the scope of it, but it actually sits beside the cochlea. And often if there's fluid in the ear, it can impact balance sometimes, or if there's hearing difficulties, it can kind of co-occur with balance issues. The fact that he's not doing well with noisy environments and he's doing better with one-to-one suggests that there could be maybe a potential conductive hearing loss there. Is he a congested child? Would he have runny noses, anything like
yeah,
that?
all the time, all the time. We spend our time wiping his nose. Yes,
So
yeah,
I suppose from
yeah,
an audiology point of view, I really want to test his ears.
yes,
I'm not going to say 100% that I know there is fluid.
yes.
And I think that the problem with fluid is it's transient. So you can go to a clinic and get tested and have no fluid and potentially leave and get sick the next day and get fluid, and that's
Yes,
the
yes.
nature, and it can be quite frustrating for parents. But I think he has definitely more than enough criteria to suggest that he would be at risk for
Okay.
otitis media with effusion. So I would push for the audiology referral, and based on that I would probably start pushing for speech and language as well.
Okay, great. Thank you so much.
No
Thank you.
problem.
Hi, Imogen.
Hi.
How are you? I am just I'm listening because I have a wee girl. She's 9 months old. She's nearly 10 months.
Okay.
And she was about 4 months, she started to have recurrent ear infections. Now she has never had a temperature with them.
Okay.
And we have been in and out to the doctor, and she has been on 3 antibiotics, one very, very strong antibiotic. She'd literally get them, and then she'd take the antibiotic, and literally within the next week, they would start again. So she was having a lot of discharge. They were very foul smelling,
Okay.
and she was just constantly in her ear. She was digging the whole time. We had wee mitts on her, trying to get her, putting her down for her naps and that. But it was just so distressing for her.
Of
So
course.
the GP put us on the list for the ENT, and 2 weeks ago we had our appointment with the ENT specialist, and yes, he was very good, and he said yes, she has glue ear.
Okay.
But currently she is on a tablet. I'm not sure if you're familiar with it. It's for her stomach. It's called Losac. She had a very bad acid reflux. um
Okay. Oh
and
yes.
yes, so since taking this tablet, her ears have cleared up.
Okay.
um, and the specialist said to me, that generally, yeah, there is a bit of a link with the acid reflux and the ear, and the tablet that she is on for her stomach would help with her ears. So at the time that I went to see the specialist, I obviously wanted her ears to be as bad as possible for him to
I know.
see. Murphy's Law, they were good. So yes, he could still see that she had glue ear, and at that point in time, he said, there's nothing you can do. There's nothing for you to do at the minute. But if and when she comes off the stomach tablet, her options would be either grommets or what was he, or this a 6-week antibiotic.
Okay.
Are you familiar with that?
I suppose it's slightly out of our remit as a speech and language therapist and audiologist, to be honest. So I'm not going to advise either way on medication.
Yes.
But there is some. I actually got your question before the presentation, and I did a little bit of research, and there is some evidence, kind of new evidence, to suggest there might be a link with acid reflux. And I suppose anything that, like, my understanding of it is that anything that can go into the throat can get into the ears, so effectively if the child is kind of getting up that reflex and it's kind of sitting in the back of her throat, there's no reason that it can't get into her ear. So I suppose from that point of view, if the tablet is keeping the acid reflux at bay, it's not letting it enter the throat, so it's not letting it into the ear. So I can see the logic behind that. Now, just from clinically working with children, I have seen ENTs recommending various different types of antibiotics and courses of treatments and so on and so forth, and sometimes it's trial and error, but sometimes it is just to keep that irritation away. And I suppose with otitis media, it's really important for the eustachian tube to stay open. So you can imagine if there's acid or fluid or whatever getting into that eustachian tube all of the time, it's going to be so irritated and swollen and closed. So that's probably where their viewpoint is, but I wouldn't like to comment either way on the child's kind of ENT management, because they would know a lot more than I would for that remit.
And
but sorry.
In terms of her speech and language, obviously she's only starting to babble and that now, but is there anything that I can do as her mummy to help or encourage that, or what is it?
I would just do as much reading, as possible to her. Obviously, she's only a tiny, tiny little baby, but, you learn so much accidentally. And I suppose, she's 9 months, so she's not quite at the 1-word mark yet, but she's getting there. So keep an eye on those kind of things. But just exposing to language as much as possible when they're young is important. So that would be my 2 cents.
Lovely. Thank you so much. I really appreciate it.
I would keep an eye on her hearing, though. She sounds like she does have chronic ear issues. So I would try and link in with kind of a good audiology team, and, really probably she needs checkups frequently. Not even for fluid, but just for infections, because, they can develop into things themselves. So I would be keeping an eye on all of that stuff.
Right. That's lovely. Thank you so much, Imogen. Thank you.
No problem.